All right, good morning, everyone. My name is Ann Fitzer, and I'm the family planning team leader at USAID's Maternal and Child Survival Program, and I will be moderating this webinar this morning. I am very excited for this webinar, and let me tell you why. And the Maternal and Child Survival Program started about 4.5 years ago. And when we started, there was really only one country that was implementing postpartum family planning at any kind of scale, and that was India. And by postpartum family planning, in this case, I mean specifically the integration of family planning with maternal health services at antenatal and maternity service delivery points. And now today, 4.5 years later, that is no longer the case. There are quite a few countries that are at scale. And as my colleagues at FP 2020 just shared with me, there are 20 countries who've committed to scale up PPFP as part of their FP 2020 commitment. And then a total of 39 countries that have mention of PPFP in their country action plan. However, to date, we've mostly relied on population-based surveys to know how these programs are performing. And I think we want to move to the point where countries have their own systems and measures to understand how well their program is doing. And so today we're going to hear about global level efforts to come to some kind of consensus of what indicators are most appropriate to integrate into HMIS systems. And then we're going to hear from two of the handful or the dozen or so countries that have made progress to update their HMIS to capture pre-discharge postpartum family planning. Those two countries are Kenya and Afghanistan. So I'm going to introduce the first speaker. Her name is Deborah Citrin. She's the Monitoring, Evaluation, and Research Advisor on my own team at MCSP. And she has a wealth of experience in M&E and research, both for family planning and newborn health. And so is very interested in that moment of time when baby comes. Without further ado, I'm going to turn it over to Deborah. Thanks.
Thanks for the introduction, Ann. And as Ann said, I'll be sharing some global recommendations on indicators for postpartum family planning that are appropriate for collecting in a national HMIS, National Health Management Information System. Next slide. So first, before I get into those recommendations, I just want to explain where they're coming from and who actually developed them. So we convened a PPFP measurement committee under the PPFP community of practice. And for anybody on the line who's not familiar with the community of practice, we can provide more information or a link to where you can find information on it on the Knowledge Gateway, if anybody's not familiar. But among those that are in the community of practice, we had quite a few organizations and projects represented in this measurement committee. They're listed here. So as you can see, we tried to get as wide of a group as we could together with experience on measuring postpartum family planning. So it was really a collaborative effort to develop these recommendations. Next slide. And then just quickly on the process, it's been about a 1-year process to develop these recommendations. We started in December 2017, and the first meeting was really just to share what we knew so far about routinely monitoring PPFP. And most importantly, we heard from several countries that were kind of early adopters of postpartum family planning indicators in their HMIS. And we really wanted to take their experiences, what they had learned so far, and their decision making on what indicators to include to inform these global recommendations. So that was the first meeting. And then we reconvened about 6 months later to develop some draft recommendations based on what we were seeing had been most feasible and useful across countries. And then after that May meeting when we developed draft recommendations, we then shared them with the entire community of practice through an online survey to elicit feedback. So it wasn't just the measurement committee that developed them, but everybody in that community of practice would have an opportunity to comment on them. And we received that feedback, and then in December of last year, we reviewed all that feedback and refine indicator recommendations, which is what I will share today. And then again, just quickly before I get into the indicator recommendations, I just want to say what assumptions we used when developing them. We really wanted to develop indicators that would measure coverage and utilization, recognizing that many countries, as Ann said, are now actually doing postpartum family planning at large scale. So we didn't want to come up with measures of service availability or readiness. We actually wanted to really think about what countries who are actively implementing should do to measure coverage or utilization. We wanted indicators that would be feasible to collect by modifying existing cross-sectional paper-based registers, recognizing that still what many, or I would say even most countries are still using. The indicators could still be collected using longitudinal registers or electronic tools if that exists in countries, but we really wanted these to be feasible for pretty much any country to collect. And lastly, we wanted the indicators that we were recommending to be appropriate for aggregating at district, national, and global level. So there might be additional data that would be appropriate to collect at a facility level to help providers provide care to their clients, but that's not what we wanted to recommend indicators that we really think should be aggregated up and useful at all levels of the system. So here's also, so at MCSP, we actually did another project, but it was related to this. So I just want to share some findings of it. And that's, we did a review of HMIS tools across 18 countries, looking at a number of indicators related to family planning. But here's just the data that we found on indicators of postpartum family planning. And you see in that first column, countries that when we initially did our review in 2017 and we had collected tools in 2015 and 16, you see that there were only 4 countries among the 18 that had some indicator of postpartum family planning in their system. But then we updated our review and we collected tools in early 2018, and you see by that point it had more than doubled, and there were 9 countries in our review that were collecting indicators of postpartum family planning. So we see really growing interest in this, that a lot of countries see this as a really important indicator because they recognize that reaching postpartum women with family planning is important to reaching their family planning target, their goals. So we see that go back for a second. So we see more and more countries are collecting it, but still at the same time, there hasn't yet been consensus on what methods to record. Some countries are only recording long-acting reversible methods such as IUDs, implants. Some countries are reporting the full spectrum of methods. So there hadn't yet been consensus of that. There's not yet consensus on what time frame to use. Some countries are collecting just the immediate postpartum, some more extended. And what register to use, there's also not agreement. Some are using delivery register, some use postnatal, some use family planning register. And then there hasn't also been consensus on whether counseling should be recorded. So the goals of our global group was to come to some agreement on what would be the best practices, recognizing though that countries have and will continue to adapt to their needs. So the recommendations I'm going to present are what we feel is the best practice so far based on the lessons we've learned, but that doesn't mean that countries shouldn't tailor it to their needs. So I just want to make that point before we actually get into the recommendations, because you'll see some differences between what we've recommended and what we'll hear later from countries of what they're actually collecting. But this is to provide guidance for countries that are just now thinking about what they want to include. The next slide. So the first recommendation is that all HMISs should include an indicator for PPFP uptake prior to discharge after birth. And the reason this was highly recommended is because the group felt it was both feasible and useful at all levels. It's feasible because the denominator, which you see here, is all facility deliveries, and all countries should be collecting that. It's a pretty clear-cut, easy denominator and pretty straightforward. And also it's feasible to collect by just adding one column to a delivery register, which pretty much all countries have a delivery register. So it's overall, relatively speaking, pretty feasible to collect and useful at all levels. Even in countries where there's a high rate of home birth, still there are women who deliver in the facilities. It's important to know that that contact is being fully optimized for postpartum family planning. So the indicator itself is % of women who deliver in a facility and initiate or leave with a modern contraceptive method prior to discharge. And I just want to also point out that the reason the wording is initiate or leave with is we want to capture women who receive a method that's inserted by a provider, such as IUD implant, women receiving tubal ligation, women who start using lactational amenorrhea method, or women who leave with a method such as pills and condoms that they can then start using after they get home. In terms of, I just want to point out that under the critical disaggregation, we do also make the point that it does include LAM. Not all countries have actually chosen to include it, but the group felt that overall we did want to recommend the countries include it because in a lot of places it is a pretty popular method, and it is very effective in those initial 6 months after birth. And it's important for countries to know how many women are choosing to adopt LAM, especially because then they need to know what services they might have to provide to women around 6 months later when women need to transition from LAM. And for countries that are not including LAM and maybe are just capturing a couple methods, we're going to overall see their coverage probably is much lower than countries where they're collecting the full spectrum. So that's important to keep in mind. And then also I just want to point out under disaggregation, we've also recommended that in countries where there's a high rate of adolescent pregnancy, that it would be important information to disaggregate by age. And then just lastly, I just also at the bottom make a point that some countries are, instead of this indicator, choosing to adopt instead PPFP initiated within 48 hours after birth. Again, the same essence is trying to capture that early uptake, but here the denominator would not just be facility births, but also births that happened at a home. And so some HMIS are set up to collect that, but that's more rare and many few are set up. So that's why in general, we're recommending the pre-discharge indicator. Next slide. Recommendation 2 is that HMIS may also include an additional indicator on family planning counseling prior to discharge. This, again, is feasible. We felt that it was reasonably feasible for the same reasons the last one was, and that it would be overall useful as a complement to that first indicator to understand is the reason that women are not taking family planning is because they're not being told about it and not giving an opportunity to take it, or is it that they are being told about it, but there's some other constraints on why uptake is low, for example. But this indicator, we recognize that some countries might be moving towards a composite indicator to measure generally the care that women receive after birth. And so instead of just an indicator on family planning counseling after birth, they could instead include a composite indicator that would include this. Next slide, please. So recommendation 3 is actually moving beyond not an indicator recommendation, because actually the group felt that we really wanted to limit how many indicators we recommend because we know HMIS are often overloaded with too many indicators. So we really wanted to keep it simple. But we do think it's a priority for countries to have tools that document whether counseling is done during antenatal care, and if a woman chooses a method, what method she chose. So it's important to document, even though we do not necessarily recommend aggregating and reporting this information. But it is a cue to action. It reminds providers to start that counseling early because there's been evidence that starting that counseling early increases uptake after birth. And also it improves the efficiencies and helps providers ensure that women who chose a method before they deliver it actually can get that method soon after birth. And here we just show in the slide where it can be documented. So it can really be, countries can choose, and maybe they even document it in more than one place, or they can choose what's most appropriate for them, whether it's documenting in the register or on an ANC card that's held at the facility, or maybe even a card that the woman holds herself, but that it should be documented somewhere. Next slide, and this is our 4th and final recommendation. We recognize that postpartum family planning can be provided beyond that initial few hours after birth. And that's really important too, that many women are not ready to take up family planning immediately after birth, or maybe some women who deliver at home will come to the facility later. And then there's also community-based services that women might get afterwards. So we want to have a recommendation for an indicator to use for that more extended postpartum family planning period. But the group, at least through those initial consultations, we didn't feel ready to recommend an indicator. We had some discussions on it, but few countries are collecting anything beyond that immediate. So we didn't feel like we had enough lessons on what's really feasible and useful to collect. So we decided that we needed some more experience and some more consultations on what to be included. But we did want to say that we do still think it's really important, and we recognize that, and we will be working on it and hopefully learning from various countries in the coming year. So that's all.
Great. Thank you, Deborah. Excellent. I think this is an excellent way to frame the next two presenters. We're going to talk about their process for advocating for revising the HMIS to capture some of these indicators. So next, I would like to introduce Mohammed Samin Soroush, who is a Research Monitoring and Evaluation Manager with the Reproductive, Maternal, Newborn, Child, and Adolescent Health Directorate of the Ministry of Public Health in Kabul, Afghanistan. Afghanistan. Thank you, Dr. Soroush. Please take it away.
Thank you, Isha. It's great to have a chance to share our experience to all attendees. So I just want to share our experience on how we are advocating and expanding PPFP services in Afghanistan. So just a short background on how we started PPFP services. So back in 2012, we just started PPFP in one of the hospitals, tertiary hospitals in Kabul, but it was not expanded at that time. But later on, in 2017, we expanded PPFP services in almost 5 provinces through USAID and GPIGO project. They were working on 54 facilities in these provinces, and as the indicators were not included in HMIS, so the programs had to collect information on postpartum family planning counseling and intake through a separate vertical recording mechanism, and they were using DHIS2 to report those and collect data. Next slide. And also at the same time, UNIFE was implementing PPFP services in 5 other provinces where we had low CPR in both public and private clinics. And again, as there wasn't any system, so they were collecting these information through midwives, through separate data collection farms. And we were facing huge problem on collecting those information nationally. Next slide. As for the strategy that we developed on 2017 and the RMCH national strategy, we had prioritized postpartum family planning as one of the effective interventions for family planning program. So emphasized were on all partners to expand these services through public and private health facilities. And at the same time, we introduced implant and emergency contraceptive. And just this year, we started the subcutaneous DMP. So all of these, so we were trying to integrate all these services and include these new methods and our national HMIs. And at the same time, we had a national summit, which in the declaration focused on interventions on PPFP nationwide. As we were prioritizing these interventions, so advocacy sessions were made to stakeholders as well as for the Ministry of Health leadership and partners, so that these indicators should be included, because as we have our HMIS is very overloaded, so it's hard to include these indicators. So advocacy was needed to make sure that we could include this indicator in the national HMIs. Next slide. So following the ICF event in November that we had in Kigali, so we, from Ministry of Health, we attended the postpartum family planning event that was held after the conference. So during that session, we had first-hand information of how Rwanda implemented PPFP services and the data collection that they had, along with the advocacy efforts that countries had to expand PPFP. So during this session, we received materials on informational materials on recommended indicators that countries could use to include new indicators on PPFP in their HMIs. And this was the best timing as we were revising HMIs, our HMIs after 7 years. So the timing was right, and we proposed these indicators to be included into HMIs. Next slide. So this is a screenshot of the recommendations that Deborah just explained. So we use this as a advocacy material and also informational material to the HMIS task force to justify that what is the best indicator that we could choose for Afghanistan to be included in HMIs. Next slide. This is just a picture of the health facilities that we visited in Rwanda and the registers and how they were using their national HMIs to record PPFP indicators, and the advocacy sessions that we had with GPIGO colleagues to develop the country action plan. Next slide. So for inclusion of these indicators, we had this task force that were meeting almost for 2 months. So we were discussing that which is the best indicator among these 4 recommended PPFP indicators to be included, and what should be the time frame of these services that we should include in our HMIs. At the same time as revising the family planning client card and the card at the health facility, as those were easy. So we started to revise those cards, and the cards were revised, and the PPFP services indicators were included in family planning cards. But yes, for now, we agreed on the task force that at least we will include the PPFP service provision for IUCD and implant immediate postpartum family planning indicators into HMIs, which is on the final stage of approval. Next slide. This is just a screenshot of the recording sheet that we have in our HMIs. So we have reporting of each method. So previously we only had recording of these cases, but now we added a new column of postpartum, so that like now for each method they can record that how many of routine cases that they had and how many of postpartum family planning method were consulted and used by clients. Next slide. So as we are finishing the revision process, so on June 2019, it is expected that the revision will complete and all the database and registers will be revised, and we will start collecting data on these indicators by July 2019. At the same time, as we are scaling up MCH handbook, maternal and child health handbook, we included PPFP and post-abortion care services indicator in the MCH handbook, which during coming 3 years, the MCH handbook program will be expanded to all 34 provinces of Afghanistan. So that's also another opportunity that we will have all those informational materials as well as indicators in the MCH handbook overall Afghanistan. Next slide. Okay, so that was all from our experience in Afghanistan. I hope this experience would help other countries who are in process of inclusion of these indicators in the HMIs. Thank you.
Thank you, Dr. Sarouche. As you can imagine, we at MCSP and at FP 2020 are very excited that the event in Kigali resulted in an action plan that was implemented and realized. So thank you so much for this really great presentation. Now I'm going to turn it over to my JPIGO colleague, Susan Ontiri, who is a Senior Monitoring and Evaluation and Research Advisor for the Advanced Family Planning Program in Kenya. And she is joined by Sally Njiri, who has been a Technical Advocacy Officer with the same program based in Nairobi. Susan and Sally, take it away.
Thank you, Anne. We'll basically share our experience on introduction of PPFP data into our HMIS. Next slide. So a bit of background information. Kenya has had tremendous growth in its contraceptive prevalence rate from the early 1970s up to the last DHS data of 2014 that indicated our contraceptive prevalence rate was at 58%, and the modern method was at 53%. But recent data from PMA round 7, which was collected in 2018 last year, indicates that we are actually at 63% and 60% for modern methods. Next. So when you look at our S-curve, where all our subnational or what we call counties lie, one of the things that has increasingly become clear is that where we have densely population, the CPR is almost growing slowly or plateauing, but we also have regions where we have a CPR of as less as 3%, which are mostly in the arid and semi-arid areas. And this realization made the country to actually look at the priorities, because in as much as on one hand, we are happy that we've actually improved our contraceptive prevalence rate, that actually led us even getting an Excel award at the 2016 ICFP conference. We have inequities and also missed opportunities that we needed to address, and postpartum family planning was listed as one of the missed opportunities that the country needed to focus on. Next. So just some big background information on postpartum family planning. In Kenya, only 19% of postpartum women begin using FP methods during the first 6 months. And when you look at a period up to 23 months, the uptake is only at 36%. In terms of unmet need, 57% of postpartum women, they actually have unmet need for family planning, of which 29% is for spacing and 28% limiting. This unmet need is even higher among when you compare with the overall women of reproductive age. And also a case for postpartum family planning was the fact that 50% of all births in Kenya occur at interpregnancy intervals of less than 23 months. Next. Kenya's policy environment actually promotes provision of postpartum family planning. We have an RH policy that is still under revision after the current one expired, and it needed to be realigned with the new governance structure of devolution. But looking at the national FP guidelines, the foundation for postpartum family planning has actually been established during antenatal care period, where counseling begins. And also the most recent revision of our national FP guidelines, which was to be in line with the WHO 2015 MEC edition, allowed or rather adapted provision of the following methods as per the MEC will. Next. So whereas the service provision arm was ready, because we had several partners, including the USAID Maternal Child and Survival Program, having programs on the same. Documentation for the same was a challenge. And in 2016, Kenya included PPFP as one of its FP 2020 commitment, which necessitated the country to actually relook at how data for the same can be collected. And following the 2016 ICFP conference, we had Family Planning Measurement Working Group, which was established as a subcommittee of the Family Planning Technical Working Group. And among its core mandate was to relook at how the metrics for PPFP will be included. In November 2016, consultative discussions with our Health Management Information System, which is basically the division that is the custodian of changes on DHIS and also reporting tools and registers, was held to actually gain some traction and show them the importance of actually modifying these registers to include FP timing that will capture the postpartum family planning period. And one of the things to note is the division of HMIS requires for any new additional element, either be it a data element or an indicator, pre-testing of the same is done for almost 2 years to basically show whether the process or the indicator is feasible and acceptable before it is rolled out nationally. So in December 2016, we began the process of generating this evidence because we had actually seen that in 2018, our health sector strategic plan of 2012 to 2018 was to expire, and it also created an opportunity to have revision of these tools. So we decided to begin this process in December 2016 so that we can have almost 1.5 years of actually collecting this evidence to coincide with the national revision of the tools. And we identified 2 counties, Migori and Makueni, to actually lead the process. Next.
For county advocacy efforts, that is in Makueni and Migori County, this was actually picked up just the way Susan has mentioned that the work at the national level was going on, and so we had to approach the county level, which is a sub-national in Kenya, to establish a technical working group for postpartum family planning and identify the challenges that were existing in the registers, and modification and pre-testing of the same tool was done. So then we moved down to engaging county directors of health to issue a circular that was actually directing the service providers to be providing the services and reporting on the postpartum data on a monthly basis. So commitment by facility data has actually took place, and out of it, we had a success of seeing adaptation from these 2 counties, collecting monthly data on postpartum family planning, and also using the same data to make decisions at the county level. Next. Inclusion of postpartum family planning indicators in the HMIS. In Kenya, review takes place after 5 years, and revision provides an opportunity to review existing indicators and data elements. An internal consensus from the reproductive health maternal unit on proposed list indicators to be included were, we had the immediate postpartum family planning within 48 hours, 3 days to 6 weeks, and post-pregnancy family planning among post-abortion family planning and others. Next. So inclusion of postpartum indicators, on the HMIS include number and percentage of clients receiving immediate postpartum family planning within 48 hours. And this data is found in family planning register, which in high volume facilities is both in the maternity and MCH. And then we have the ANC register documenting cancelling of family planning, of pregnant women cancelled on family planning. Then we have the postnatal register, which has a column on family planning initiated during postpartum clinic visits. Next. So we have a process of inclusion of indicators in the HMIS where we have an internal consensus on indicators within the reproductive health and maternal health unit. A lot of discussions go on here to actually identify which indicators needs to be put into the HMIS. Then there's a meeting with the HMIS team to just clarify on the proposed changes. Then we have a stakeholders meeting to build a consensus and review burden on healthcare providers. And then lastly, we have the national printing and dissemination of the revised tool. So precisely in Kenya today, we are hoping to have the next step, which is stakeholders meeting, most likely this month, and then we will move to the printing once the consensus had been arrived at. Next. So out of this process of implementation, right from the national and the sub-county sub-county approaches, we learned a lot of lessons, and key lessons that we picked from here, we have understanding the government process of reviewing indicators is very critical because you have to begin the discussion right when they start thinking through this, and then using a multi-pronged approach to guarantee results. When we say this is actually the bottom-up approach. When we moved to counties to start working with them, this really acted as an evidence that this postpartum data can be collected and be reported on a monthly basis. And with this evidence, the counties can now be able to make decisions out of it. Then inclusion of PPFP as a key agenda in the National FP Measurements Working Group is critical. So anytime there's a discussion with the National Technical Working Group, then the PPFP agenda becomes as part of the key agendas for discussion. Then lastly, one of the things that you also need to consider that it's good and nice to report all the indicators, but always think of the burden to the healthcare providers. So as much as we would want to report many of these indicators, we also want to look at how much burden are we giving the healthcare providers. Next. Well, thank you.
Great, thank you, Susan and Sally. That's I really appreciate that your process, one, focused on the equity issues in Kenya for access to family planning in general and to postpartum women in particular, and that you really outlined a process that was very smart. I also like the fact that even though it's not aggregated and reported, you included post-abortion family planning in your HMIS review process. At this stage, I think we're going to turn to the Q&A process. And as Isha mentioned early in the webinar, you can type your question in the Q&A portion of the platform. But I think some questions have already come in while the presenters were speaking. And we're going to start with a question about Deborah's presentation related to the inclusion or lack of inclusion of certain countries in that slide, capturing which countries have already incorporated PPFP indicators. In particular, the questioner asked about Zimbabwe. So, Deborah.
Yes, thanks, An. And that slide shown with some countries that are collecting PPFP, that's definitely not comprehensive. That was just a selection of 18 countries where we had done a review of the HMIS tools. Those countries were selected based on a combination of what were USAID priority countries, where MCSP currently had programming, and so we had someone to talk to because it was a little back and forth as we were trying to collect the tools and understand what was in the tools. And also we just had to restrict the number of countries when we did the review because it was a massive amount of work to gather the tools, interpret it, and all that. So we definitely couldn't include everything. So just because it's not there doesn't mean PPFP is not collected. And I just want to also point out that at that first meeting where we were actually talking about indicators, I mentioned we heard from some countries that were early adopters, and that included Rwanda, Guinea, and Burkina Faso. So while Guinea and Burkina Faso were not in our activity to review HMIS, they definitely have PPFP indicators, and we had heard from them and what they were collecting, and that was really useful to guiding our discussion. So maybe someday we could expand that review to additional countries, but we couldn't at the time. Thanks.
Great, thanks, Deb. There's another one for you, specifically about your recommendation regarding, or the group's recommendation regarding lactational amenorrhea method. This is from Celia Karp, and she asked, what is the most appropriate way to capture the adoption of LAM? Should it specifically ask or record the woman's plan to breastfeed exclusively, breastfeed for a specific duration, whether 6 months or less, or stop using this method once menses return? So basically, how much of the detailed counseling on LAM should be recorded? Or should it just be her intention to, at least for the short term, breastfeed exclusively? The questioner is concerned that capturing LAM sort of overestimates actual PPFP use. I don't know if you have thoughts on this.
Yeah, this is something the group really talked about a lot, and there was a lot of back and forth about including LAM, and recognizing that we really can't capture a lot of detail. It's very hard in registers, to say how long a woman's planning to use it and all that is just too much for a system. Often they just maybe have a column where you can check off a method, or a single column for all the methods, and all they can do is write in code, like a 3-letter code for each method adopted. So we really cannot capture much detail. I think the essence of what we wanted was to understand how many women truly understanding what LAM is and choosing to adopt it. And no, we don't know how long they're going to actually use it. As same with condoms, pills, we don't know how long, a woman could stop using it. And same with any, many methods, a woman can have it removed, or, she can stop. Other than permanent methods, she basically can stop at any time. So we didn't want to hold LAM to a different standard than we hold other methods. But that really the counseling providers need training and need perhaps job aids to help them with the counseling of women. But that's kind of where the group landed.
Great. Yes, I think offering a full spectrum of methods is also a client rights issue. So that is another reason potentially for not excluding some methods over others. I'm now going to turn it over to Dr. Sarouche. There is a question that came in asking you to expand a little bit on some of the challenges you had in this advocacy to prioritize PPFP and its measurement. And I'm going to expand on that question a little bit and ask you whether in that advocacy process to date, there's been a role for subnational level stakeholders to engage, or what you see in terms of future needs for advocacy at the subnational level to make sure they use the data that will now be collected. So Dr. Sarouche.
Sure. So regarding the challenges that we had, it was mostly regarding on how we, which programs should be prioritized more, because we had, at our MCH, we had over 30 indicators that we wanted to include in HMIS. So then the question was that whether PPP is the most important one among comparing to other new indicators, like we were including implant, cyanoparase, and others. So it was also needed more advocacy among team and our partners that this is a priority, and we want to have this information collected, as we don't want to miss the chance on this category of women who deliver at clinic. So basically, it came up to that as this priority for the program. So it should be, regardless of number of indicators that we include. So this should be added, and somehow leadership us to convince them to include it. That was the challenge that we faced. And the subnational level partners, they were not engaged at this level, although we had partners at the national level who were engaged in this discussion. But of course, as soon as it gets included in the HMIS, so we may even include in our scorecard, provincial level scorecard, so that at the subnational level, they use this data and help the implement program correctly.
Great, thank you for that. I'm going to turn it over to Sue and Sally, and you guys can decide who's going to take the question. I think you've gotten a lot of interest in the chat box of people who want to hear a little bit more about the pre-testing process at the county level. And I think, there may be interest in understanding whether stakeholders at the county level or at the national level have different priorities or different concerns that you had to smooth over. And in general, so some of the same question of what were some of the challenges and bottlenecks that you had to overcome. Someone also specifically asked about the NACC, and unfortunately I don't know what that stands for.
So the issue of pre-testing is, as I'd mentioned earlier, Kenya has a devolved form of government where we have the national level, and the mandate of the national level is basically to come up with policies and guidelines that will be implemented at subnational level, county level. So the moment the national government, and particularly the Reproductive Maternal Health Services Unit, included PPFP as a national agenda and even added it as one of its FP 2020 commitment, that meant that it bound all the 47 counties to abide by it. So the process of pre-testing that happened for around 1 year in Makueni and Migori County, and we also had other programs in Meru County, was basically to show the evidence. And we started by having modifying tools, because the current FP register that is being used did not capture anything about postpartum family planning. Postpartum family planning was only in the postnatal care register, just as one column where a healthcare worker will tick whether the client has basically received postpartum family planning method. But in a country where our stillbirth coverage is in the ranges of 60, we still have quite a huge chunk of home deliveries, and it necessitated to have that column included in the family planning register, because that is the source document for documenting all FP services. The collaboration with the National AIDS Control Body for this work of postpartum family planning, there weren't involved, but in other works, for instance, the discussions on the ECHO trial, we are having collaborations between the family planning programs and also the HIV programs for the country.
Great, thank you. I might turn to a question that's come in about the issue of having to reprint all the HMIS support tools, and sort of what are the country level concerns about that, and how, you know, are there advocacy related issues or issues and concerns that advocates should be aware of when they're asking for HMISs to be revised? So maybe Dr. Sarouche, you could go first.
Yes, sure. So for us, as we revised the whole HMIS, and there is not only RNCH indicator, but other program indicators will also be revised. So like they all know that in July, there will be a new revision. So all clinics, like they will only supply current register till July. So they are prepared to receive the new registers and formats for data collection by then. So the implementers are ready to use the new registers and print them. But of course, if it is not a regular revision and we include these indicators in the middle of the year, so there might be problem with the printing and supply of registers. But as for us, it won't be a problem, as the overall system will use the new registers and the data collection systems.
Sue, do you want, or Sally, do you want to add anything?
So in Kenya, as the participant has correctly observed, revision of tools and register is such an expensive process, because what happens is the HMIS unit has to organize printing. In Kenya, we have over 9,000 facilities. So you can imagine printing all those registers and reporting to. And that is why major revision of HMIS happens every 5 years to realign with the Kenya's health sector strategic plan. But in between every 2 years, there is always that revision of any additional element. For instance, you may have some data elements that are captured within the registers at the facility, but they are not, they don't trickle upwards to DHIS. So every 2 years, we have that window period of actually including indicators in DHIS. But the major revision happens every 5 years. There is a lot of advocacy that goes into it because of resource. It's quite an intensive process. And just like Afghanistan, this does not just confine to the family planning tools, it is health sector wide. So we have to have a lot of, government has to put in money, and also other partners to complement what the government has allocated to actually enable printing of all these registers and tools. And not just there, to even disseminate, because with these new changes, it means healthcare workers have to be oriented on the revised tools and the revised indicators to improve data reporting.
Great. Actually, there was another question that came in and I should have combined it. And it had to do, it came from Nana Dagadu about the length of time for this revision process. As advocates, what are your lessons learned about what to expect in terms of duration of time? Susan, you want to start, or Kenya start, and then Afghanistan?
Okay, in Kenya, we know that major revision of HMIS is every 5 years. So basically you have to work backwards. And that's why we even started the process in 2016, because we knew in 2018 we will have that major revision. So we needed to put systems in place so that by the time the major revision happens, we've already collected evidence to actually present to the stakeholders and the HMIS to actually show. So it's not cast on stone. You just need to be smart enough to realign your efforts to make sure that by the time the revision, like right now, we know the next revision will happen in 2023. We have all the processes, we've pre-tested, we have consensus between the technical units and even the county level before HMIS comes in.
Sure.
Dr. Suresh, do you want to add? Yes, go ahead.
Yes. And for us in Afghanistan, we started on September 2018 with the initial meetings on which indicators should be revised, and it is still continuing. So the whole process will take around 9 months for us till July when we complete the revision process.
Hi, so okay, one final country level question. Solomon Orero asked about post-abortion family planning. He asked about both the first and second trimester, so I'm not sure if that is asking what Kenya is going to do about this, but he specifically directed his question at you, Dr. Sarouche. Are you capturing post-abortion care in your system? Post-abortion family planning?
So for us, we haven't collected that information yet, but among the indicators that we proposed, post-abortion care indicators are included, and post-abortion family planning is one of those. We might not have the segregation by trimester. It will be on the register, but as they are reporting to the national level, they will just report the numbers. So the post-abortion family planning is one of the ones that we will be including. It hasn't been agreed yet, but in the next meeting, that's how the committee will decide on its inclusion.
Great. Anything to add from Kenya?
No, we also don't have the segregation by trimester. We just have post-abortion care that takes care of all the levels. Post-abortion family planning, I mean.
Okay, great. And then, so one final question as we're getting close to time. I'm going to turn that over to Deb. If a country is earlier in the process of revising their HMIS than Kenya or Afghanistan, what are some of the resources that you suggest they should look for or learn from to carry out this process, experiences from other countries and so forth?
That's a good question. And it actually comes back, I think, a little bit to that question on printing and the cost of it. And what we've learned and we've seen, this came out in Kenya, but just to talk about it again, and we saw it in Rwanda, is if you're pilot testing this or doing it in a small number of facilities to see how it goes, learn some lessons, to be able to bring that to the national level, we were able to actually use the existing registers, which didn't have PPFP, but almost all paper-based registers, whether they have just a little space in the margin, or sometimes they have a column where a provider can write in comments. We could often use that, or in the case of Kenya, they actually used they put a stamp that they gave to the facilities where they were testing it, and they would stamp in the register to create space for recording postpartum family planning. So there's almost always a way, because it doesn't take a whole lot of space to just, at least in the delivery register, record the very basic minimal information, which is the number of women getting postpartum family planning before discharge. You can always do it with existing tools without having to reprint anything. You still, of course, have to orient providers, but we did that as part of we're training providers anyway on how to do PPIUD insertions or how to do better counseling on postpartum family planning, and adding in just a few minutes to talk to the providers about recording it in the register really doesn't add much. And so you definitely can, in the interim, record the data. And then you have to, of course, gather it to get a little bit of a sense of what's happening. So again, in Kenya, we had added to their summary reporting form just a little line that they would use at the facility level to aggregate. So it wasn't being entered into DHIS2 because it was just on a paper-based form, but at least it provides enough information and enough learning that when you get to that moment when the national HMIS is ready to revise, you have all the evidence that you need, you have experience, you could even bring in some providers to talk about their experience collecting the information and at a facility level, how they used it. So that could be really valuable and sets up countries well. But like both countries said, you know, you really have to plan backwards and start planning for that, to do that well in advance of when you're expecting a revision to happen. So you're ready for it.
Okay, and Deb, let me ask you again, or one final thing. For those global recommendations that you presented, beyond the slides that were shared today, is there a document that's available online?
So we're working on a brief to explain the recommendations, and so we are hopefully going to have that ready to share very soon. We wanted to include logos from all the organizations that participated in the conversations, but we'll have that soon to share. Also, we've developed indicator reference sheets, so some more detailed information on the actual definition and how you calculate the indicators, and we've been working with Measure Evaluation to put that. They have an online family planning reproductive health database where they have indicator reference sheets for many indicators, so we're planning to include it there. So we're trying to make it as available as possible, and we want to put it on the FP 2020 website. So we'll try to get it out there as soon and as easily available as possible.
Excellent. Well, I think that concludes our time for this webinar. And I want to extend great thanks on behalf of MCSP to FP 2020 for hosting the webinar, and to Dr. Sarouche and Sally and Susan and Deb for their presentations, which I think were very rich and portray that this is not an easy process. It requires the advocates' keen understanding of and networking to decipher what the process is in their local context, and how to provide the level of evidence and to convince decision makers to incorporate these new postpartum family planning indicators. And every country is different and will make different decisions, but we're fortunate that we have soon to come out some recommendation, or we have the recommendations already, but the brief is soon to come out to share the global consensus of this working group with feedback from some 30 countries on the recommended indicators. So I think we're hoping that in the next 4 or 5 years, countries are even better equipped to accelerate and advance services for postpartum women at the time of delivery. With that, I will close the webinar and hope to see you in an upcoming event hosted by FP 2020. Have a good day or good evening.